Good morning, everybody. My name is Dr. Jaslyn Doshi, and I would like to thank you for warmly welcoming and inviting me to this conference. I feel very privileged to be here among all of you. I am from University of Sydney in Australia. My background is that I'm an infectious diseases physician. I work very closely with respiratory doctors at my work, as well as in my research that I've done in Vietnam a few years ago. And I am very privileged to be here to discuss this big challenge that we have on antimicrobial resistance that faces respiratory physicians, infectious diseases physicians, and the whole community, really. So thank you. And it's a big topic, so we'll try and see how much we can cover. So this is something that we all know. Antimicrobial resistance is a term that we use about how we use antimicrobials and what it has done to develop resistance over time. So as you know, antibiotics were only discovered less than 100 years ago, with penicillin only being about 90-something years old now. And since then, we have discovered a lot of different antibiotics, antivirals, antifungals, and these are agents that we use to fight infections. However, in the last 100 years, because of how we have used our antibiotics, we have developed, what has happened is these bacteria, these fungi, these viruses are much smarter than us and have developed resistance using many various mechanisms. So the primary drivers of antimicrobial resistance is the overuse of antimicrobials and the misuse of antimicrobials. So when we use too much of it or when we use it inappropriately, what happens is these microorganisms evolve to resist the effects of antimicrobials. The way they do this is by developing new genes of resistance. They are also developing efflux pumps. They are developing biofilms, and all of these are the ways that the antibiotics now, the microorganisms now are able to resist the antibiotics. What happens? Standard treatments become ineffective, and then the infections persist. There's higher risk of spread, higher morbidity, higher mortality, and inevitably also costs more for the healthcare. A little bit of a diagram to show how antibiotic resistance spreads. So just the mere use of antibiotics. Mostly we discuss about how antibiotics are used by humans and how when we use a lot of it, that can circulate in different healthcare facilities, in different settings that they are. But the other important thing to remember is that even when we use antibiotics in animals, where it's used in farming or in the cultivation of animals and as well as production of our food, this can develop drug-resistant bacteria. It remains on the meat of the animals. It remains in the fertilizer or water-containing animal feces and contaminates our environment. And that means you develop antibiotic resistance that persists everywhere. So it's in our environment, it's in our food, it's on us, it's in healthcare facilities, it's everywhere. So unfortunately, it just shows that just the mere use of antibiotics can cause resistance. We talk mainly about antibiotics because that's where we have the most evidence for, but really there's resistance in even antifungals and antivirals. But antibiotics is where our biggest problem lies. So I'll give a bit of a context of AMR, which is antimicrobial resistance in Vietnam. Now, Vietnam has one of the highest rates of antimicrobial resistance in the world. In 2019, there were about 14,000 deaths attributable to AMR, and even more, 52,000 deaths that were associated with AMR. And if you look at this chart, it's only the third cause of morbidity and mortality after cardiovascular diseases and malignancy. So that's actually showing us that it's such a big problem that's causing a lot of morbidity and mortality in our patients. Like we talked about, the users, the drivers of antimicrobial resistance, one is overuse, using too much. Antimicrobials accounted for about 1/3 of the total spend of medications in public hospitals in Vietnam. And when studies have showed that between 2000 and 2015, Vietnam ranked 11th globally in total antimicrobial consumption. That's in hospitals, in the community, and overall estimate. But however, in a more recent study published just 2 years ago in 2023, it showed that now it has crept up to being the highest antimicrobial consumption amongst 67 countries that were studied. Now, this shows that there's a highest relative increase in consumption of more than 100% between 2016 to 2023. So it's quite evident that the consumption is just a big problem. Now, it's not just the fact that we use antibiotics, it is also the misuse of antibiotics. So when it's required, that is okay. But when it's not required and antibiotics are used, that's when the problem rises. So approximately 1/3 of inpatient antibiotic use has been reported to be inappropriate in Vietnam. That's the stats that's been released by WHO. But if you look at the literature, other studies have quoted between 40% to 80% of inappropriate prescribing. And this is when they reference to the National Ministry of Health guidelines. The study that I was involved with, that I will talk about a bit later, called the VRESIST study, actually quoted up to 70 to 80% inappropriate prescribing in district hospitals, which was our target population in Vietnam, using a standard audit tool that was adapted from Australia, but referenced on our antimicrobial guidelines that were based off the MOH guidelines. In the outpatient setting, where patients are being seen in the community, inappropriate antibiotics have been given to up to 92% of common viral infections. So I'm sure this is not news. We all know that there's a lot of antibiotics being thrown around and it's very easy to access it. Why is it important in respiratory infections? Respiratory infections are one of the most common indications for antibiotic use globally, not just here, everywhere in the world. A large study that was conducted in Vietnam in 2023 showed that almost 200,000 acute respiratory infections in commune health centers in 6 rural districts showed that almost everyone was prescribed with an antibiotic. And that was for pharyngitis, bronchitis, viral influenza, basically any upper respiratory or viral or respiratory type infection. Another study showed that a pediatric outpatient department showed that 90% of children were getting inappropriate prescriptions as well. So this is just, again, highlighting that our population, no matter where we look, are getting a lot of antibiotics. The most common organisms in the community, we are still seeing Streptococcus pneumoniae and Haemophilus influenzae. They are the 2 most common causative pathogens of community-acquired pneumonia, both in children and in adults. We're also seeing Klebsiella pneumonia and Pseudomonas being other common causative pathogens, and these are where we're seeing more and more resistance creep up. One study in rural Vietnam showed the resistance patterns of strep pneumonia that has increased in preschool children between the ages of around 5, increased from about 30% up to 80% over a 15-year period. So we are seeing that the resistance is evolving over time. Another study has looked at the resistance patterns of these organisms. So this one in particular is the Strep pneumoniae. I'll point over here. So if you have a look, oral antibiotics sensitivities are very low, as we already know. Penicillin, very difficult. There's no chance of using it. Penicillin IV is a bit better, but you'll see mainly it's your fluoroquinolones, your third generation cephalosporins. Those are the ones that it has maintained sensitivities to. This graph on the right shows the evolution over time. So 2009 to 2011 to 2016, 2018. And you can see that the numbers are reducing. So penicillin IV from 87% has dropped to 60%. Amoxiclav, which is a really great drug and it's in most guidelines, also is dropping in resistance. And that's 2018, so I'm sure by now that's even lower. And a lot of very common oral antibiotics that we all use and prescribe every day, their resistance are dropping. Same for Haemophilus influenzae. Same year periods, you'll see that the reduction in ampicillin, amoxiclav is actually still pretty decent, which is good. But you know, oral antibiotics, cefuroxime, is all consistent problems. So that is what we see overall in the community. There's also a more in-depth study that was done by the Ministry of Health looking at organisms that were isolated in 16 hospitals around the country. However, the caveat is that these are all tertiary hospitals. So in tertiary hospitals, you're going to be seeing very complex infections. And what we have seen here is that the organisms grown is very different to what we normally see. So you get Acinetobacter baumannii, which is a very resistant organism. The Klebsiella pneumoniae are also quite resistant, and Pseudomonas ranked amongst the most commonly isolated pathogens. So what we're seeing is that what we see in the population and then in the lower level hospitals, by the time they get severe enough and present to tertiary hospitals, the organisms that's causing pneumonia is actually quite difficult to treat by then. I plucked this from the report and it was translated, so it's not translated very well, and the lines don't correspond very well, but it's just to show that Klebsiella pneumoniae, you know, the simple antibiotics are a big problem, and we are now needing to reach to our carbapenems, amikacin, for treating these infections. Resistance has also increased based on data that was captured. This was a 2020 report, but compared to a 2012 report. Same with Acinetobacter baumannii, as it is that particular organism is already very resistant. Carbapenem is usually what we use. However, if you look here, carbapenem sensitivities is actually quite low, which is a problem. Same thing with Pseudomonas. So the final thing I wanted to say is that another issue we see in infections in hospitalized patients is that it can sometimes go for longer, or a more severe approach is taken. Diagnosis of pneumonia in hospitals is variable. The use of scoring index or severity indexing tools is not standardized. So severe versus non-severe pneumonia is categorized very differently. So that just means a lot of patients are being diagnosed as severe pneumonia, being put on IV antibiotics for a prolonged period of time, when actually it's not as severe as it would be if we were to use the tools. So, you know, these patients are not on oral antibiotics when they need to be. They're not de-escalated from IV to oral when they should be. And sometimes there's also the issue of using a single agent when a combination of 2 antibiotics is required, or vice versa. There's a combination when only a single antibiotic is required. So lots of different things. And I wanted to then switch towards, okay, we all know antibiotic resistance is a problem. We all know overuse, misuse is a problem. What do we do about it? This is a series of projects that I was involved with a large team in Vietnam that was looking at how we could implement antimicrobial stewardship in the grassroots levels of the country. So we looked at district hospitals. I know there's been a restructure, and now that's the terminology is regional health facilities, but basically what we were looking at is at that level, the presentations of most of the Vietnamese community would be to district hospitals. So how can we try to improve our antibiotic use in that level of hospitals where there is lesser resources and less specialists in that level of healthcare facility. So we instituted a series of studies called the V-Resist studies. We had a pilot study where we looked at the feasibility before and after the implementation of AMS interventions, and then followed by a cluster randomized control trial of 16 district hospitals in 2 provinces, so in Hanoi and Cà Mau, where there were 8 intervention sites and 8 control sites where we implemented AMS interventions. Now, this was at the same time that the government had released a decision about implementing AMS in every level of healthcare facility in Vietnam. So it worked really well. There was a government document to say this is what we need to do, but this was a study for us to see how we can actually implement it hands-on in those facilities. The objectives, we wanted to see if an AMS program is feasible in a district hospital setting where the resources are lower. We wanted to check how does antimicrobial consumption look like in this level, and what are the changes before and after the intervention. The appropriateness of prescribing using a validated audit tool. So we used an audit tool that we adapted from Australia, because when you look at studies to assess appropriateness, there are various different ways we can assess it. This is a validated tool that's been used in several countries and looks at lots of different aspects to see how appropriate an antibiotic is. And also we looked at mortality and costs. What is an AMS intervention? Antimicrobial stewardship is just a way we implement activities that help educate and encourage the use of antibiotics properly. The way we do that is we establish AMS committees and AMS teams in these healthcare facilities. As you probably all know, it's well-resourced in tertiary hospitals to have this, but not all district hospitals had this consistently. So this was something that was very useful to create in a district hospital setting. We had a committee that had all the heads of departments of different departments. We had AMS team that at least had 1 doctor and 1 pharmacist, clinical pharmacist, and if they had experience in infectious diseases, even better. We developed and implemented antibiotic guidelines that was specific for district hospitals, and it was based on the Ministry of Health guidelines. We did training, we did workshops to educate people about antibiotics, so these are the healthcare workers. And we also implemented the most important intervention called audit and feedback, where regularly across the intervention period, we did audits of antibiotic use, and then straight after provided feedback to the departments about how their use were. This is a snapshot of what we did. We had the audit and feedback sessions. So this is a group of doctors where we're having a look at what they prescribed and what the guidelines are and what could be changed. We did training sessions on how to use the audit tool. We did training on what AMS is, on scenarios of antibiotic use, what can be done. And we also had AMS meetings regularly. So that meant we were keeping track of how the hospital was going. Overall, there was use and distribution of the guidelines. I won't go through point by point, but basically we discussed and distributed material to say this is how we manage community-acquired pneumonia as per the guideline. These are the antibiotic choices. We also gave practical scenarios. If a patient comes with this, and had this medical problems, what would you do? And we made scenarios for doctors to practice on. This is a bit hard to see, but there was also a different set of guidelines for children and pediatric cases, because like you know, we see a lot of pediatric respiratory infections. Audit and feedback was our mainstay intervention. We used this template, and it was translated as well for the team to execute, where we wrote down the antibiotics that were used, the dose, the frequency, what route, IV or oral or IM, whether the indication was known, and all of the criteria as to whether it is appropriate or not. I've put a bit of some examples just to show the method of what we go through. So we take all the patient particulars down, and we write, okay, on that day, the patient was on cefotaxime for pneumonia. And all of the reasons as to whether it's inappropriate or not, it's not relevant because this is an appropriate indication for this patient who had antibiotics escalated due to persistence of fevers. So that means it's a 1. It's compliant to guidelines and it's appropriate. In another scenario, a pediatric patient was put on 2 antibiotics that were very broad spectrum, ceftriaxone and gentamicin. And in this scenario, we found that it's very inappropriate because the spectrum is too broad. So then they go under suboptimal as an appropriateness. So there's a whole list and a very systematic way that we categorized all these antibiotics. Another example was in an indication where it was a viral infection. It was very obvious that it was a viral infection, and the patient was still prescribed antibiotics. So in this case, we would say antibiotics is not required at all. So their appropriateness levels goes down to 4, which is inadequate. So those are a few examples. I won't go through them all because I don't have much time. But I wanted to talk about the challenges we faced. This was just the start, and we saw that there were so many problems that we faced implementing the activities, which made us think in the future, these are the challenges that we need to try and improve on. For one, the antimicrobials guidelines that we used the National Ministry of Health guidelines, which, as you know, was updated in 2015. But since then, there's various versions of particular infections in different forms, and they're found everywhere online, and it's very hard to have one standardized place where everything is that is used by everyone. So because there's so many guidelines, that means there's so many different advice out there, and it means that people get confused, which is understandable. If you have so many guidelines, you just pick one and you may or may not use it. That just means that that's where AMS is going to go down the drain. The other thing is, in these guidelines, the list of antibiotics not necessarily abides by AMS principles. You can have the most narrow spectrum all the way to the most broad spectrum all listed there. So as a healthcare worker, you don't know what to pick. You're going to pick the strongest one because you're worried. But that's not the right way to do that in AMS. We also saw a lot of challenges with patients with viral infections. We had problems with drug shortages. So when there was no particular antibiotic, they had to pick something else. There was a lot of inappropriate dosing, where a lot of antibiotics were dosed less than what it should be. If it should be 4 times a day, it was only given twice a day. And as you know, this breeds more resistance because not enough antibiotics there to kill the infection, and you keep going for a long time, you're just going to get the stronger resistant bacteria to stay on. A lot of healthcare workers reported they needed to justify why a patient is in hospital. So I have to give antibiotics. Otherwise, why is the patient here? And there was a lot of prolonged use of IV antibiotics, a lot of prolonged duration of antibiotics. Even though there were all these challenges, we still saw that, look, we know the problem is there, but it is feasible in this setting, even though we have less resources. It's feasible to do AMS interventions, and we must try, and we must continue to do it. The consumption in antibiotics did reduce in the pilot study, but it did not in our RCT. Our inappropriate prescribing was still very high across all sites, but it did show that with interventions, it reduced slightly. So it does suggest that inappropriate antibiotics does reduce with AMS program, especially the audit and feedback. Other learnings that we had, it's very important to involve clinical pharmacists. They have a lot of knowledge about the use of antibiotics and what to use when we don't have the particular drug, or if something is not available. I think they are, and dosing antibiotics. I think they are very valuable. District hospitals obviously have limited access to microbiology, and that's a work in progress over time. It's a difficult issue, but there are ways around it. Drug supply is also a problem. Ongoing education using clinical scenarios we found was very useful to teach healthcare workers, and updating our guidelines based on the current antibiograms are very important, because as you saw, what was resistant in 2015 is even more resistant now. So there is so much importance in having one guideline that is accurate. And having local AMS champions, which was pretty much my entire team, who are really there advocating for AMS in the local hospitals, is the most important thing, because people will be encouraged if their own people are influencing them to use antibiotics properly. Next steps for us, we are trying to see how we can scale up our program. We are talking about our next phase involving more district hospitals, which are now regional health facilities in other provinces, and also talking about devising an AMS program handbook that's specific for health facilities. Sorry, I've gone over time, but that in a nutshell is the problems and what we try to do about it. So thank you very much.
Okay.